pleasure to introduce Professor Joseph Wu. It's an honor, and that's also, I would say, for us something new because we just moved our building into the new building, and it is the first seminar that we are organizing. Still, we have to figure it out the details, but it's great to have, I would say, to open the series. We have probably, about 200 seminars a year. So, Joseph, you are opening now, I hope, what is going to be a long series of contribution to the debate and the discussion. Professor Wu is the Sir Robert Kotewall Professor in Public Health in the Hong Kong School of Medicine, and he has probably, I don't want to say too much about your age, but at least 15 plus years of experience in infectious disease modeling, analysis, analytics, and now he's also moving into other, I would say, use of analytics and modeling in medicine, including cancer, and so he has a large activity. He has played a major role in many of the health emergencies of the past few years, including obviously COVID, but as well he has been active on MERS, on I think you did also then foot and mouth disease
yes.
work, and so it's really a pleasure to have him here. And I met him when we were young. Among the many roles that he has is also the chief editor of Epidemics and an editor of PLOS Computational Biology. So, how to say, it's a reference person when you will submit your papers. Remember, he's the person that will deal with your science. Today, we will talk about preparing for vaccine hesitancy in future pandemics. I think it is going to be a review of the experience and what had to manage the COVID-19. Please, the floor is yours.
Thank you, Alex, and thank you for having me here today. So as Alex has mentioned, in this talk, I'm going to talk about, it's more like a sharing session, my own perspective on how we can prepare for vaccine hesitancy in future pandemics, given what we have learned and observed during the COVID-19 pandemic worldwide. As, again, Alex has mentioned, I am a data scientist, epidemiologist, engineer. I'm not really a person in health communication, but I got interested in vaccine hesitancy about 10 years ago when Heidi Larson, who headed the Vaccine Confidence Project, she was one of the first persons to start working on vaccine hesitancy 2-3 decades ago, when most people didn't, including the global health experts, were still not viewing that as a major global health threat. So she came to Hong Kong U about some time ago, and we met, and she talked about her work and my work, which was at that time seems to be there was not much overlap between what we do, because she has been working at the UN for a long period of time, observing what is happening in low middle income countries on how to improve or just maintain vaccine coverage among children for the EPI vaccines. Whereas I was a data scientist, analyzing epi data, building models, building simulations, building forecasts. And then over the years, we kept talking, and as she shared her experience and work, I started to feel that there's a lot more data scientists and epidemiologists should account for in terms of what's happening in the vaccine hesitancy landscape. So this is why I say this is more like a perspective sharing rather than a research talk. And I would like to first start by a quote from Walt Ornstein, whom I have the honor to work with at the WHO. We worked together for 5 years on one of the WHO committees called IVREC, which is about vaccine implementation at the global level. So Walt was the director of the of the US National Immunization Program for more than 10 years. And he was also one of the major contributors in the smallpox eradication effort in the 1970s. And in one of his very notable article, the title was "Vaccine Don't Save Lives, Vaccinations Save Lives." So what he meant was that in order for vaccines to have impact at the population level, of course, we need to have safe and effective vaccines. That's the product. That's the biomedical products that we need. And once we have this technology, we have to have these products made available and accessible to people whom we intend to immunize. But at the end, people have to accept these interventions, these preventive interventions, in a timely manner in order for vaccine to have impact. So I think for most people before COVID who worked in the field of vaccinology, including myself, we have mostly been focusing on the first 3, and then sometimes the 4th and 5th dimension, but less so on the last 2 steps. And in order to, I think this is blocking. So one of the painful lessons that we learned in Hong Kong about the importance of timely acceptance of vaccinations was what happened when Omicron emerged and spread in 2022 in Hong Kong. So some background information, because I think most of colleagues here are not familiar with the COVID time course in Hong Kong. So Hong Kong, for the first 2 years of the pandemic, was able to suppress the spread of COVID-19 by imposing very stringent social distancing measure. So the cumulative incidence was less than 1% for the first 2 years, aligning with the policy in mainland China. But when the Omicron variant emerged, BA2 variant emerged in 2022 and started spreading in Hong Kong, what used to work in the first 2 years against more ancestral variants no longer worked for Omicron because BA2 was just too transmissible. And when Omicron started spreading in January 2022, more than 50% of those aged 60 or above remained unvaccinated in Hong Kong. So I think most of colleagues here in this room remember that old age, especially those older than 60 years of age, and also those with comorbidities, were the high-risk groups in terms of clinical severity. In particular, if infected, this group is 5 to 10 times more likely to require hospitalizations or dying from COVID-19 infection. Unfortunately, for the first 2 years of the pandemic, in Hong Kong, we weren't able to persuade this high-risk group to get vaccinated. And as a result, 96% of COVID deaths during the first 3 months of Omicron spread in Hong Kong occurred in this age group. And I think for a week or two, Hong Kong had the highest mortality rate globally. So imagine going from almost completely suppressing COVID spread in the first 2 years to be on a news headline that Hong Kong had the highest death rate of COVID for a week or two. There was this very painful lesson, especially in contrast with what happened in New Zealand. So the situation in New Zealand was quite similar to Hong Kong for the first 2 years. They were also able to suppress the spread, until Omicron spread. But unlike us, they were able to vaccinate a substantial proportion, I think more than 80%, 90% of their high-risk populations. And as a result, if you compare the case fatality ratio of COVID-19 between Hong Kong and New Zealand during the Omicron epidemics worldwide, there was about 10 to 20 times difference because of timely acceptance of immunization in New Zealand, but not in Hong Kong. So that was a painful lesson that we hope would not happen again in future pandemics. And the issue of vaccine hesitancy is actually not new, although it's kind of new to many of those who work in vaccinology, but the problem itself, the phenomena, was not new. Before COVID in 2019, the WHO listed vaccine hesitancy as one of the top 10 global health threats. So this was before COVID. It wasn't because of COVID. And so you can still find this list on their webpage. And what they mean by vaccine hesitancy in this list is the reluctance or refusal to vaccinate despite the availability of vaccines. So this is not a definition that I think most people who work in this field agree on now. They have updated the definition, which I will show you in a short while. But this is just to show you that it's not a new problem. It's actually a problem that has been threatening global health for a long time, as Heidi has shown in her work in the past 2 to 3 decades. So the new definition of vaccine hesitancy is, first is a psychological state. Specifically, it's a motivational state of being conflicted about or opposed to getting vaccinated. And this includes both intentions and willingness. Unlike most what the general public thinks when they hear the word vaccine hesitancy, it's not really just a binary divide between pro-vaccine versus anti-vaccine sentiments. It's a complex dynamic continuum in the sense that it's highly context-specific. It depends on at what point in time we are talking to the subject, which vaccines we are talking about. So people feel very differently between, say, HPV vaccine versus influenza vaccine versus COVID vaccine. Oftentimes, people don't agree on if you ask them the same questions about a portfolio of vaccines. And as we've witnessed during the pandemic, is strongly driven by events. For example, headlines about adverse events after immunization, conspiracy theory, misinformation, the necessity of getting vaccinated, etc. So it's a continuum. It fluctuates even within the same individual over time. And it's also influenced by societal factors. For example, as again, we have observed it during the pandemic, it could be politicized as a tool, as an instrument for promoting certain agenda by different stakeholders. Okay. It's not a new challenge. Vaccine hesitancy is as old as immunization itself. So the first form of immunization, as you know, is the smallpox variolation, which started about 300 years ago. And since then, whenever authorities try to promote or even mandate vaccination, there has always been protest, resistance, etc. And over time, it has different forms of resistance has emerged. But in the latest 2 to 3 decades, information, the access to information and also the digital advances has made this a lot worse. For example, I think in the age of modern medicine, the most notable driving force for vaccine hesitancy was the article that Wakefield published it in The Lancet in 1998. In this article, he conducted a very small study, fewer than 20 subjects, I think, claiming an association between measles vaccination, and autism. So it created a lot of controversies when this was first published. And long story short, after 10 years of investigation by the academic community, this study that was published in The Lancet eventually was found and confirmed it to be fraudulent, and was eventually retracted 10 years after its first publication. But of course, as you can imagine, a lot of damage has been done over these 10 years. And Wakefield actually, I think at the moment is in the States. So he was a doctor in the UK when he published this article. His medical license was revoked after the study was confirmed to be fraudulent. So he, I think after some time, moved to the States. But you can Google him. He's doing quite well in the sense that, as mentioned earlier, vaccine hesitancy is a very polarizing topic. So apart from being an important topic in science, it is also a very useful tool for different purposes, attracting business opportunities, attracting internet traffic, etc. So this basically opened a new avenue, basically in fighting people who don't believe in vaccines and associating with something that we don't have an answer to. For example, the cause of autism. And during COVID, of course, there were many different stories that affect the acceptance of COVID vaccines, including whether COVID itself is real, including whether the vaccines is safe, especially the mRNA technology platform, and also some old conspiracy theories, such as the Gates Foundation is a strong proponent on getting people immunized against COVID, especially for people in the low and middle income countries. And people start saying that, okay, this is an effort by Gates to implant microchips into people to monitor their daily lives, basically. But stories of such they're not new. Actually, if you look back in past health emergencies, such as the 2009 swine flu pandemic, people said the same thing. It was again Gates. It was again microchips and similar things. So basically, old stories. But whenever we have a new, especially at the global level, health emergency, the same tricks work. It will attract some proportion of the population to listen to your stories, and then these stakeholders could take advantage of that to fit whatever agenda that they're trying to push. So because vaccine hesitancy is a psychological state, as you can expect, there's substantial disparity among different demographic groups, and also volatility even for the same group of people over time. So these are some evidence I gathered as examples. On the left is data from the Wellcome Trust Global Monitor Project. I think this is one of the first and most widely cited data source on what vaccine hesitancy is really about at a global level. So if this data is new to you, you may find the main finding surprising. So in this figure, from top to bottom, we have the level of vaccine hesitancy measured as the percentage of people who report that they believe vaccines are safe. Okay, so further to the left means people are more vaccine hesitant or even anti-vaccination. To the right are people who have stronger confidence in vaccine safety. So in this project, the researchers basically there's a survey, it's a global survey in different parts of the world, asking different people in different continents from top to bottom, many questions, and vaccine safety is one of them. So if you look at the top, Asia, what you see as the country that has the lowest vaccine confidence might be surprising to you. This might be too small for you to see, but it's here at about 35% or so. And that country was Japan, a highly educated country. And people who have the strongest confidence in vaccines in Asia was Bangladesh and India, much lower literacy level. So again, if this data is new to you, you may find this perplexing, because a priori you may expect more educated people to have stronger confidence in vaccine safety, because there has been a lot of medical evidence showing that most vaccines that we have included in EPI, for example, have been tested to be safe in many, many different clinical trials and field studies. But if you look at other continents, in particular, Americas, green in here, we find a similar pattern, that country with the lowest vaccine confidence in this data set, the United States, at about 70%, slightly over 70%, versus country that has the highest vaccine confidence level, which is, in this case, Venezuela, 90-something percent. So it seems that it's not an artifact, it's real. And indeed, there have been studies both before this Wellcome Trust study and also after supporting that. It's not just about information. It's not just about education. It's about a lot of other things. As we've just talked about in the previous slide, it's highly context specific. So that's the disparity dimension. And on the volatility dimension, this is a study from the Lancet, published before, I think either during COVID or slightly before that. Not talking about COVID, still talking about just whether people generally think that vaccines are safe, not specifically naming which vaccines. 2015 versus 2018, so 3 years apart. As you can see here, same country could have substantial changes in vaccine confidence level. For example, Australia here went from around 70 to 80% down to 50 to 60%, whereas Canada is the opposite. Went from 50-something percent to 70-something percent. So it changed over time, even within the same country. And here's data on during COVID about COVID vaccines, that is not just at the national level. It's basically at any spatial level, any geographical spatial level. So this, in this study, the population was being asked, why do you think COVID vaccines were safe? And as you can see here, at the state level, city level, county level, there's substantial heterogeneity. And it also changed over time. So this was a survey study conducted by Jeffrey Lazarus Group in, I think, City University of New York in 2023. So again, global survey, but also comparing to the older versions of the survey that they've done over the first and second year of COVID. Showing that first, of course, as you can expect, there are substantial disparities of vaccine confidence across countries, but also over time. Okay, so they compared the statistics in this 2023 survey with similar survey that they've done in 2022 and 2021. And what they found was that there was some substantial changes in some countries. For example, for India, it increased by 20 to 30% compared to the first year of pandemic. Whereas for South Africa, there was about 40% drop.
Yeah, so I don't know if you're going to talk about it later, but it seems a lot that is related to also politics. In the US map, you see politics in terms of
right.
states, also in the countries that you were talking about.
Yes.
Things like, for example, Venezuela, where it's a country where over the years whoever was taking care of the politics had a lot of influence. Since like India could be also what happens against other countries where, let's say, in quotes, like there is more freedom or change more.
But
The opposite.
politics, government definitely is a strong driver in vaccine confidence, but it's not the only. But it is one of the strong factors, which is closely related to the first pillar that I'm trying to share with you guys, which is trust. In particular, trust in government, trust in health officials, trust in science. Okay, so of course, there has been research trying to understand the drivers for vaccine hesitancy. There are external drivers, for example, politics, which we've just talked about. But at the more fundamental level, the first model, so-called 3C model, was introduced in 2013. So in the 3C refers to confidence, complacency, and convenience. We can talk about in more details what these dimension means. And then over the years, 3C evolved to become the 5C models, and including two additional dimensions: collective responsibility, which refers to when people decide whether to get vaccinated. Sometimes it's not just about protection for themselves. Sometimes it's also about protecting your close contacts, especially household members who have comorbidities, for example, or small children. And also so-called calculations. Information are now very accessible, in terms of the scientific facts. So when people now, compared to say 10, 15 years ago, trying to make a decision on whether to get vaccinated, they would get the information and basically make the internal calculations on risk versus benefits. So there has been studies showing that the 5C model consistently is able to explain 20 to 40% of vaccination behavior globally. But note that this was 2018. As we have discussed, vaccine hesitancy is a psychological state. It fluctuates substantially over time, not just the level, but also the underlying drivers. So 20 to 40% was the old number. Whether this model is the 5C model is still capable to explain substantial variation in vaccine confidence. We don't have newer data on that yet. Okay, so what are these 5Cs? Well, confidence, as the word suggests, means trust in safety and effectiveness of vaccines. I think this is an obvious prerequisite, but not sufficient. People also have to trust the healthcare system that is delivering the vaccines. For example, are the vaccines, is the cold chain reliable, basically? And also the advocates behind vaccination. For example, is the government recommending the vaccines or not recommending the vaccines? Are the health experts uniform in their recommendations? Not just whether they are technically trustworthy, but also whether their motives are trustworthy. So I think all of us have heard during COVID that some people resist vaccines because they argue that, well, this is a big, conspiracy between the big pharmas and the politicians, so that the pharmaceutical companies could make huge profits by vaccinating the entire global population. Complacency refers to perceived low risk of vaccine preventable diseases. So basically, is it necessary or important for a person to get immunized? Obviously, this depends on the clinical consequence of vaccination, which is different for different people. For example, for COVID-19, older people tends to be 10 times more likely to have severe clinical outcome if infected. So it's different for different people. And this was a dimension that we didn't do well in Hong Kong because the high-risk people thought it wasn't necessary to get vaccinated against COVID because we did so well in suppressing the spread in the first 2 years. But then a new strain emerged, which was more transmissible. So that assumption that worked during the first 2 years no longer worked. But when that change happened, there was not enough time for the high-risk people to get vaccinated, and therefore we had high death rates. Constraints refer to both exogenous barrier, for example, whether the vaccines are accessible and affordable to people, and also psychological barriers, for example, whether these people have the motivation to get themselves vaccinated, or are they being affected by the norms among people around them. For example, social norms at workplace, social norms at religious groups, for those that are religious. I think these are very strong forces shaping vaccine hesitancy. Calculation, as mentioned earlier, refers to people who do their sort of internal weighting between the risks and benefits of getting vaccinated. And then finally, as shared earlier, collective responsibility. So these are the 5 C's. I think this is the most commonly used model in these days. It's the basic model, not the complete model, for understanding vaccine hesitancy. And which brings me to what I think is the most important thing we could do in order to get better prepared for vaccine hesitancy in the future, which is building trust. Because over the years, there have been substantial evidence showing that there are interventions that may be effective for complacent, convenient, and calculating individuals. Okay, so these are more manageable dimension of the 5 C's. But interventions that might be effective for those who lack confidence are scarce. So this was well recognized that, well before COVID. In particular, as you would expect, the most trusted sources for vaccine confidence could differ among different people, but typically they are doctors and primary care providers, nurses, pharmacists, and other healthcare professionals, family and close friends, community and faith leaders, and public health agencies and scientists. And these were much talked about in the vaccine and trust document that was prepared by the WHO, again, well before COVID. So there was substantial research evidence to support that. It's just that at practice, or the general public didn't quite appreciate that this is sort of like what's shaping their psychology about vaccines in reality. This was an article in Science that Heidi Larson wrote. Title is Vaccine Trust and the Limits of Information. So again, sort of saying that vaccine hesitancy is not just an information problem. It's not that people are not receiving or the accurate information, or accurate information is not accessible. It's trust, which is much, much harder to tackle, because even the word itself, trust, what does that mean? For one thing, trust is about the messenger. For many communities, the messenger is the intervention. So if people trust the messenger, sometimes it's not so much about the message. As a bad example, I think we have seen news headlines about cults that preach about doomsday and encourage people the members of their group to do something very extreme to get prepared for that. So the same message can have very, very different effects depending on where it comes from, whether it's from a trust or distrusted entity. And here are some notable recent work on that topic. On the left is a global, not a global survey, but almost a global survey, 23 countries in 2023, showing that trust in the 11 selected source of vaccine information averaged less than 10 on a 10-point scale. So when they say selected source of vaccine information is basically this list, where it's from, is it from doctors, is it from your friends or families, from your community leaders, for example. So I think the major takeaway from this paper is that even the most trusted source it's not a perfect 10 or anything close to 10. It's just at most a 7. So there's this gap, 3-point gap. Why are people not having high level of trust, even among the most trusted source? The second paper here shows that respondents reporting high level of trust in information from government sources were more likely to accept a vaccine and take their employer's advice to do so. So this study was done during the first year of COVID when vaccines were not yet available. So it was a hypothetical question. So this shows people who, relating to the question that was raised 10 minutes ago, trust in government is very important. Third study shows that in countries with a high aggregate level of trust in science, people are more likely to be confident about vaccination over and above their individual level scientific trust. So this is related to the second study, the conclusion that, of course, each of us has some internal demographic factors that affect our own trust in vaccines. But if the same kind of person in different countries with different level of trust in the government, and this environment also impose an impact and influence on the personal level of trust in vaccine. Again, emphasizing that it's not just about what the person thinks, it's also the surroundings, the environmental factors, the exogenous factors, in particular, trust in governments. And then finally, a perspective from, again, Heidi's group, talking about the challenge of vaccine hesitancy is not just, again, an information problem. It often has little to do with the vaccine themselves, actually, especially during times of uncertainties. Which brings me to the second pillar for preparation for vaccine hesitancy in future pandemics, which is nowcasting. So this is related to what Heidi said in her article, that people lack trust when there's high level of uncertainty. And pandemic, almost by definition, is such event at the global level, where the world is dealing with a new pathogen. We're not sure what intervention, both pharmaceutical and non-pharmaceutical interventions would work. So during high level of uncertainties, during times of high level of uncertainties, in particular in the context of epidemics, nowcasting is one of the best things we can do in order to address those uncertainty, because what we do in nowcasting is basically to make the best use of available information from different data sources in order to get the best assessments in terms of the pathogenic, epidemiological, clinical, and social behavioral characteristics of the epidemics. So this schematic here, I think this is one of the most frequently cited schematic by me in my talks. It was a schematic prepared by Mark Lipsitch and Mauricio shortly after the swine flu pandemic. So I think many of you have seen this before, but if not, it basically has 4 different levels. The first are the decisions that policymakers is trying to make or government is trying to make in response to a new epidemic event. So ranging from, for example, overall scope of response. Are we dealing with a highly transmissible pathogen that has high clinical severity, in which case the response should be at the highest level? Or are we dealing with a low transmissible pathogen with a low clinical severity? In order to make that decisions, ideally, we need evidence. So for example, R0, incubation period, clinical severity, case fatality ratio, these are the first few epi parameters that we try to get a good estimates on during the early stages of any epidemic, especially those when we talk about novel pathogens. And in order to synthesize this evidence, we need the data. This is the third layer, surveillance inputs. So basically data coming from, say, hospitals in terms of how many people admitted suffer severe clinical consequences or even die. Serological surveillance, for example, taking blood samples from the population to see whether people have pre-existing immunities, or over time, whether seroprevalence increases, in which case that might reflect the proportion of population infected if immunization has not happened yet. So basically, assimilating all these data sources in order to synthesize the evidence to inform decision. And the bottom layer are the tools that we develop, the models, the analytics that we develop in order to make that happen. I think as we have all experienced during pandemic, this whole process is like the old parable of blind man and the elephants, that each of us, not just locally, but globally, have access to different data sources. But these data sources are often fraught with errors, noisiness, under-ascertainment, all sorts of distortment from the reality that generates these data. So it's kind of like we're in the dark, touching different parts of the elephant, and collectively we're trying to figure out what is this thing that we are seeing or dealing with. And nowcasting is that process. We're trying to make the best use of what is available to us in terms of data access to piece together, on a daily basis, what is our latest estimate of our assessments. And the objective is to provide situational awareness and to inform decisions about control measures. So, and in particular, to assess and address uncertainty, because I think as the general public, when the whole city, the whole country, or the whole globe is dealing with a new health threat, they want answers, right? Even if, as scientists or health officials, even if we cannot provide a direct, accurate answer, what we could do in order to address that uncertainty is to tell the public that these are the things that we are working on in order to lower the level of uncertainty over time. We're doing something, and these are the things that we're doing. And also, of course, to be transparent that these are the things that we don't know yet. Okay, so that's what nowcasting is about. And we have made a lot of progress, I think, over the past 2 to 3 decades. For example, comparing 2009 swine flu pandemic with COVID-19 pandemic. During 2009, genomic surveillance, in particular real-time, almost real-time genomic surveillance, was not a reality. It was only places with very, very high level of resources could do that at small scale. That was 2009. But during COVID, we were able to do almost near real-time genomic surveillance at the global level. For example, thanks to platforms such as GSAID and Nextstrain, genomic information of different variants around the globe could be shared in almost real time to inform decision. And however, during COVID, vaccine uptake data were not available in real time in most places. And the uptake data themselves, they are useful, but they're not sufficient because they don't tell you what was driving the low uptake or high uptake. In order to inform control measures, you want to know about the drivers, not just about the outcome in terms of vaccine uptake. So very few studies or surveillance have been looking at the underlying drivers and barriers during COVID. And this is something that I hope could be improved in future pandemics, just like genomic surveillance has improved substantially between 2009 swine flu pandemic and COVID-19 pandemic. Because compared to the disease itself, vaccine hesitancy is arguably associated with greater disparities and volatility because it's a psychological state. So we need real-time, frequent data to basically to be current with what the public is thinking about in terms of acceptance to vaccines. Especially because of the digital advances that we have achieved in the past 5 to 10 years. One of the things that, as data scientists, as modelers, one of the things that is important to know is whether there's a so-called homophily or clustering, associative mixing among unvaccinated people. So going back to the first few minutes of my talk, when I share with you the painful lessons from Hong Kong, the deaths primarily occurred among clustered high-risk people, unvaccinated people, especially those residing in nursing home facilities. So when you have clustering of unvaccinated people, this would highly affect our estimates of vaccine impact. So if you're a modeler, if you're just taking, vaccine uptake data on average, even with age-stratified data, if you don't know about how strongly unvaccinated people hang out with each other, that might substantially affect your estimates of vaccine impact, especially when in some parameter regions, for example, when the post-vaccination reproductive number is near control level, and you're aiming at herd immunity threshold. So this clustering could substantially change your conclusion, as some of the studies that was performed during COVID has illustrated. So on the left is a study from Canada, Canadian group. It's based on some survey data plus simulation. And this is the best paper I could find in the literature with data on this topic, how much clustering is happening among unvaccinated people or undervaccinated people during COVID. And even that data is not very good. This is basically self-reported data. For example, you ask the subject to make an assessment on what do you think is the uptake level around people that you hang out with, your colleagues or family members, etc. It's not objective data. And some policies can actually make this clustering effect worse. For example, vaccine mandate. Some jurisdictions, including Hong Kong and France, did enact vaccine mandates during 2022. This did push up the vaccine uptake level at the population level. Because, for example, in Hong Kong, if you were not vaccinated during those times, you would not be allowed to go to restaurants or go to large public spaces such as shopping malls. But at the same time, you are pushing the unvaccinated people to cluster together, to hang out with each other, which could create pockets of vulnerability, similar to what happened in measles outbreaks here in Canada, that the measles outbreak occur in communities where there are patches or clustering of unvaccinated or undervaccinated children. But at the national level, the measles vaccination uptake is still above 90%. Okay, so why is digital advances a double-edged sword? I mean, it could help us to tackle vaccine hesitancy, but at the same time, it could make our job much more difficult. Reason is that unlike older days, communication today is far more horizontal. Previously, when I was younger, 30 years ago, people tend to trust their health authorities, especially those being reported in news headlines. But these days, previously trusted authorities are now challenged on a daily basis by freely available online arsenal of information on TikTok, on digital social media. So I think for most people today, when we receive information or seek information, we are not going to news channel anymore. We are going to digital social platform, TikTok or in China, Xiaohongshu. And this is a very fertile ground for spreading misinformation. And once spread, misinformation is very difficult to eradicate. And once trust is lost, it's very difficult to regain, as supported by recent research. Here I show a few. This study here, published in Science, shows that, unsurprisingly, I think many of us have already found out from our own experience that falsehood in the digital space spread much faster compared to truth. This study here shows that, fortunately, there could be some interventions that could mitigate that. For example, if you sort of prompt people to seek verification of the information that they're receiving, then it's much more likely that they would do so before accepting the information that they receive. The study in the middle shows that, again, unsurprisingly, misinformation could adversely affect vaccination intent. This was done during COVID in the UK and USA. So this shows that if you expose a person to some misinformation piece, even with immediate correction, that could reduce the intention to get vaccinated against COVID by 6 percentage points. So this was a hypothetical study, but sort of shows that once exposed it, even with immediate correction, that has an imprinting effect on people's confidence in vaccines. And then finally, the study here shows that when we say misinformation, we are focusing on those information that are factually wrong, either purposely, created for some by some stakeholders, or sort of like misinterpretation of factual information. But these are relatively, this misinformation is a relatively small proportion of the content in the digital information space. So this study found that compared to outright misinformation, what they call vaccine skeptical content collectively have much stronger impact. So vaccine skeptical content means, for example, we have a news headline saying that a person just suffered from a cardiac arrest after getting immunized without making a causal link. But some people might say, oh, the vaccine might not be safe. Okay, it's not saying that the vaccine caused the cardiac event, but the vaccine might not as safe as we thought. So these sort of like vaccine skeptical contents, per exposure, they have much weaker effect compared to outright misinformation. But they're much more prevalent, and they're much harder to detect and stop. So what this study found is that, looking at data from Facebook, collectively, these content has a much, much stronger impact on vaccine acceptance during COVID compared to actual misinformation. And in our group, as I mentioned earlier, we started working with Heidi's group in the past few years, and one of the effort is on thinking about how Gen AI could help us to deal with vaccine hesitancy. This was an article written by Heidi and her co-director, Lisa, who is with us today here. And in one of the study that we have conducted in the past few years, we created a chatbot. So this was after ChatGPT became a household name. We created a chatbot to see whether it could be effective in improving HPV uptake among female middle school students in China. So the situation, the HPV vaccination landscape in China is very different from that in other parts of the world, because China is a big country. So, and China does have an intention to roll out routine HPV vaccination for adolescent girls. But before they do that, as a national effort, they want to make sure that the vaccine supply will be stable. And in order to do that, they wanted to develop their own domestic vaccine technology, because it's a huge country. If they rely on a foreign supplier, that might create some supply chain issue. So, now, that's why the vaccine uptake of HPV vaccine has been lagging behind many different other countries in the world. But in the recent 2-3 years, they have successfully developed very effective, very safe HPV vaccines. So now they are just about starting to immunize the entire country. So we did this because in 2024, they were just about starting to do that. They just committed to the program, I think, a few months ago in December 2025. So this was done before that. And what we try to do is to see whether the bot compared to control group, which is typical, public health messaging by local health officials, whether the bots could help people to build first knowledge about vaccine safety and effectiveness, and also whether it will actually have an impact on uptake. So this was conducted in several different geographical settings in both rural and urban areas. It was a cluster randomized RCT with about 2,700 parents from 180 middle schools. So pretty standard control interventions, but at the school level. The primary outcome is the received or scheduled appointments of HPV vaccines for the subject's daughter within 2 weeks after enrollment. So it's kind of a short period follow-up, 2 weeks, because if we look at a longer time horizon, there could be other factors affecting the vaccine uptake of the subject's daughter. So we thought, 2 weeks was striking a balance between not too short to observe any impact and not too long, such that there might be strong confounding factors. And long story short, what we found was that the intervention group had about 4 times higher, 3 to 4 times higher vaccine uptake. So that was the primary outcome compared to the control group. And not only that, the level of HPV vaccine specific consultation with healthcare officials after exposure to the intervention was also 2 to 3 times higher. So this means that even though people may not get their daughters vaccinated or scheduled to get vaccinated, they might make an appointment or do something, engagement with the health officials to ask more about vaccine safe HPV vaccines. And so in conclusion, we thought that this kind of intervention, Gen AI-based intervention, could be a potential solution, not to solve the problem, but to alleviate vaccine hesitancy, especially among people in low resource setting, because once developed, anybody with an internet connection could have access to the intervention, especially those in rural areas. And indeed, we found that in the rural parts of our study, the effect size of our intervention was a bit stronger compared to the urban counterparts. If you have more questions about this particular study, I'm sure that Lisa is happy to talk with you. So in conclusion, these are some of the takeaways. Timely vaccine acceptance was a critical weak link in the pathway of vaccine impact in many countries during COVID, but for different reasons. So for Hong Kong, it was because of complacency and the rapid spread of Omicron. It wasn't because of that we didn't have safe and effective vaccines in a timely manner. It wasn't because we were strongly polarized politically in Hong Kong. In other places, it was different. Second, trust in those delivering vaccine messages is essential for building vaccine confidence. And trust, as you expect, can't be searched on demand. So the only solution is really to build trust during peacetime in preparation for the next pandemic. Trust is especially brittle during times of high uncertainty. And again, by definition, that's what pandemic is about. And nowcasting is the key for first assessing, then communicating and reducing uncertainty. So that's why From my perspective, I think, once if we have the trust from the public before the event, then during the event, during the health emergency, doing very good nowcasting, especially not just about the epi dimension, but also the vaccine safety, vaccine confidence dimension would be important. And at the moment, nowcasting vaccine hesitancy is still a major gap compared to clinical and genomic surveillance, and must be strengthened for future pandemics. And I'm hopeful that this could happen in the next pandemic as genomic surveillance has advanced substantially during COVID. That's all I would like to share with you today. Thank you for listening.
Thank you very much, Jonathan. This is great, and at the same time, it's touching on a very big issue. Questions? I have to break the ice with mine, because you talk a lot about building trust, obviously, and you talked also answering the question on polarization of politics, on really, I would say, how the trust to the government. But now we are in a situation in which in many, at least Western countries, the government itself doesn't trust vaccines. So in a sense, is opening a complete new era. Is not, the government and the agencies and the practitioners that are trying to convince the public and wants the trust of the public. At this point, even, if I would be the public, I would say, well, even the government doesn't trust that. So first of all, my question is, what is the situation in Hong Kong and China in general with respect to the government scene? And the other thing is how we fight now this as a new kind of really landscape.
So in Hong Kong, and I think if we're talking about COVID and flu, which are closely related these days, people also have high level of hesitancy about COVID vaccine and flu vaccine. But again, for different reasons. It's not that our government or health officials, unlike here in the States, are openly discrediting the vaccine, but they're not strongly advocating it. And flu has always been difficult because first, the vaccine themselves are not great in reducing susceptibility to infection. It's moderately effective in reducing symptomatic diseases, like 60-70% when you have good match between the vaccine strain and the circulating strain. But sometimes if you got it wrong, it could be down to like 20% or even no protection at all. And you have to do it every year. So as understandably, general public got tired, hearing the same story. And flu is also confusing because in Chinese culture, flu, not many people can tell the difference between flu, influenza infection, and cold, and just sort of like respiratory diseases caused by a bunch of other things like RSV or pneumococcal diseases. So most common stories that you typically hear from people who say, I'm not going to do flu vaccination anymore, is that I got it last year or the year before, and I still got very sick. Actually, I got more sick than before getting the vaccine. So flu vaccine has always been difficult to promote. And I think COVID is kind of the same story because it's all also evolving quite quickly. Plus, we just had a pandemic. And in Hong Kong and China, after 2023, I think collectively, both the governments and the general public, few people wanted to revisit the topic of COVID anymore. They just want to move forward. For example, the economy might be a more important concern for most people rather than let's look back at what we did. So at the moment, that's the landscape at the moment. But for something else, RSV vaccine, for example, is a hot topic. Governments are very interested in learning about how best to deploy the new generation of RSV vaccines. PCV is also very topical because we have more and more serotypes in PCV. We are now using PCV 20 now. So it depends on which vaccines we're talking about. And in general, I think the Chinese government is not vaccine hesitant or anti-vaccination. Like I've mentioned just a moment ago, they just push out the national immunization program for HPV vaccination for adolescent girls. So I think, at the highest level, if the government thinks that from a health perspective and an economic perspective, it is beneficial for the country to go forward with immunization of a certain type, they would do so. It hasn't been used as a tool for politics or commercial purposes as what might have happened here in some contexts. So that's my observation.
It's facts, but the issue is that, as you say, if you don't push proactively the message, and actually in some cases you walk back from some policies, from access, as you were saying, then the things becomes a mixed message that is introducing also is breaking another link in the trust process. So that is what is worrying me, is that at this point it's very difficult to talk about. You have to trust your public health officials, and then
so I think
in many places here, even the public health officials are not openly talking about
So that is the understanding of the situation itself, I think, is already an important step. Again, as data scientists, as modelers, when we build models, when we do simulations, when we make forecasts, we have to make some assumptions, right? Especially about when you talk about immunization, what might be the coverage among different demographics group. So I think just the awareness that, okay, it might not be as high as we thought. So I think when I first came here, I chatted with Alex.
Nowadays we're doing scenarios where the level is so low that actually, yeah, please.
So those are super interesting, and so just for how I understand the argument, what we care about is vaccine uptake, and we want to understand the drivers of vaccine uptake, and one of the important drivers is trust. So this is trying to understand really uptake, and hesitancy here being about trust and skepticism. I'm curious about how the Hong Kong story and the HPV vaccine fit into that story. So, one way of the understanding hesitancy, you can tell me if this is wrong, but it's too much trust. But there's a sense that this is under control, so there's this sort of sense that a vaccine because people know what they're doing, they're taking care of this. I trust what's working. It's working. There's an issue of too much trust as opposed to lack of trust. And then with the HPV vaccine, to what extent is it there's a question of as opposed to a sense of overcoming about the vaccine? How do you think about the ignorance as an orthogonal question of trust in this sort of setting?
So on complacency, in the context of the 5C model, is about perceived risk of the disease, which is closely related to whether it's important or necessary to get vaccinated. So HPV uptake in Hong Kong is very good. it was COVID vaccine uptake among the high-risk groups in my presentation. That complacency was the reason why we had high number of deaths, because for the high-risk group during the first 2 years, the high-risk people were complacent. They were too confident on how well our control would be effective. It has been effective for the first 2 years, but it wasn't anymore when the news variant emerged. So it was the complacency among this high-risk group people that result in low uptake among them and eventually high deaths among them. For HPV vaccine, Hong Kong has been very, very, very good in terms of doing the communication. I think we've been doing this for 15 years or so. So people understand that it's primarily a vaccine for cervical cancer. And that's why we are prioritizing young girls for the vaccine. At the same time, they're being very careful not to talk too much about the other potential benefits of the vaccine. For example, it's an HPV vaccine, and there are many other cancers associated with HPV, including oropharyngeal cancer, penile cancer, vaginal cancer. But the health official deliberately take a step back and not talk too much about it, because they understand that some public might actually be less likely to vaccinate their daughter if you explicitly say that this is a STI vaccine. And if we talk too much about STI, people might not focus on just the disease. They might start thinking about identity. Some may say, oh, my daughter would not need an STI vaccine because she won't be fooling around. There's no need for that. So for HPV, the communication job has been done quite well. We have higher than 90% coverage among the young girls. The other bad example is Japan. Japan, more than a decade ago, for some reason, there was story coverage on adverse events after immunization, shortly after the country started vaccinating, recommending the vaccine actually, not just vaccinating the population. There were groups of, I think, women who suffer some adverse events nationally, and then claim that there's a link between such events and the immunization. Long story short, it was later shown to be unrelated. But for some reason, the government pulled their recommendation shortly after this happens. I think it was politically driven. And they didn't pull the vaccines off the market. The government just stopped it, recommending it. But at the same time, the government or some, I don't know whether they're governmental entities or official entities, but the reporter who covered this story, which eventually proved to be right in terms of saying that, well, these events were not related to the vaccine. The reporter was being persecuted for a prolonged period. So although the vaccine was not pulled off the market, although the government didn't outright say that we don't recommend taking the vaccine, but the fact that the reporter who covered the story and was eventually turned out to be correct was persecuted. This created a lot of problems. So over the past decade, HPV vaccine coverage was nearly zero in Japan. It only just started 2 years ago. The government again come out and say, okay, we are recommending the vaccine again now. But people these days still are very hesitant about the vaccine. And we're actually doing a few studies in Japan looking at that. So I think, again, going back to at the beginning of the talk, hesitancy is a complex subject. Really depends on which vaccine you talk about, which population, at what times, after what event. And and who you're talking to. You know, there might be life experience of a certain group that strongly affects their sentiments, especially when you talk about religious groups or support group, for example, children, parents of autistic children. So they have history that you need to address.
For that study, China at the time, they studied without very available to vaccine, but only as like areas. So what they do is, so our study actually was focusing mainly on addressing misinformation, concerns, and then delay actually. So and the delay actually caused we from first of all, they are waiting. Some of the parents waiting for hopefully freely available vaccine that become available in their neighborhood. The other actually mainly is they have heard a lot about the efficacy of the foreign made vaccines available on the market. In the industry, at least in China, market in China. But then they are waiting. So, but then the price is very high. So in that sense, they are waiting. So the calculation that they are waiting to see that financial incentives, whether it's going to be financially subsidized, or if actually the free domestic made vaccine available in China at that time when we did the study was 2 valent or 3 valent. Whereas Merck, at least level, would be 9 valent. So they had that impression that 9 valent is way better than 2 or 3. So they're thinking, should we waiting for domestic manufacturer be able to create something equivalent, or am I waiting for better ones for my daughter? So these are the decision making they have to go through, and then therefore at that time we're thinking that could be important vehicle for us to vote for it, at least for clarifying the information. So itself, I would say that for chatbot, we are also doing other studies around chatbot in other countries. I would say that chatbot, I think, is not a solution, but it's an important communication channel that can be used within China in the context that we promoted that chatbot within the school system. So it was important again. According to what Joe said, messenger is important. Chatbot is not the messenger. It's the school, the system behind it that was the messenger. So the same study that we, for example, we replicate study in Japan and in other contexts, it may not have the same effects. We started to see that, for example, it does improve literacy in the study that we run in Japan, but then the uptake was lower than what we would like to see compared to the time studies. And it is because what Joe was saying, the context itself matters a lot. And then Japan, they have a long history of vaccine. We have to roll several articles about that. And that has political reasons, that has their own dynamic reasons. They have their the dynamic between the medical and treatment that has to be addressed before they start. And usually, some of the doctors are reluctant to take the responsibility to recommend something they are not sure of. And then so they themselves reflect that hesitancy. So therefore, the chatbot itself in Japan may not be as effective if we're thinking about addressing, but improving literacy, yes. That's the issue.
Question? Thank you very much.
Thank you. Thank you, everybody.